Welcome back to The New Norm. I'm Dr. Lou Graham, and this is brought to you by Midway Dental and Catapult Education. The new news today, which is quite appropriate, is the FDA finally approved saliva testing. FDA approval. This was a lab out of Rutgers, and there are many labs doing this, and I'm so happy that it has been FDA approved. So really, why saliva testing? So saliva testing has become really hot, but it really goes back to understanding a few facts of what's really going on here. What we know about COVID is that the virus it's really actually attracted to a specific enzyme in the body, and it's an angiotensin type enzyme, and it is almost like a lining or a coating in certain cell membranes. Now, why do I tell you that? Well, we're going to call it ACE2+. We'll just call it ACE2+. ACE2+ has been known, obviously, to be in the lungs, and as the virus penetrates into the lungs, this is where it spreads and can often become deadly. But ACE2+ is also in the cell membranes of the heart, the intestines, and kidneys. So where else would it be, and why is saliva testing critical? Well, in 2011, there was a study done, and it was a limited study, but I think groundbreaking study. And what the study showed was that as the virus enters the nose or your mouth, it immediately targets the epithelial cells of the saliva glands. And this is critical. So what this means is that as the virus infiltrates, and testing the nose is far less, we think, diagnostic than saliva testing, it accumulates around these epithelial cells. So the conclusion of the study was that saliva testing, this is 11 years ago when they were looking at SARS, which is a COVID virus or coronavirus, that they were looking at that we could be diagnosing earlier with saliva and also thinking more prevention. So now that's 2011, let's flash forward to 2020, and we're in this pandemic. About 3 weeks ago, I'm talking to my good friend Tanya Dunlap, who's my guest today. She's the president of Perio-Protect. And she tells me about the saliva testing lab, which is what we've been talking about, along with the antibody testing, about this lab called MicroGen-DX, or MicroGen-X, but it has specific virus testing via saliva. So 3 weeks ago, we were all over this, and now the FDA has shifted into understanding, obviously, that the saliva protocol for testing, which will be great for dentists and becoming part of our protocols, will also be great for our patients. Okay, with that said, I have more to share about prevention. And so last week, Tanya Dunlap, first off, Tanya, good morning. Say hello to the group if you don't mind.
Good morning. It's good to be with you. I appreciate the chance to talk to you and the group, Lou. I hope this information is helpful for everybody.
It's great to be with you. First off, you've been literally almost a dear friend to Aaron and I in the Catapult group now for 5+ years. I can't thank you enough about your friendship. And we went back and tested Perio-Protect as a company at Catapult 5+ years ago. And I can say with 400+ patients already gone through refractory treatment in my office and other treatments, it's an amazing system. Well, the company itself was founded by Dwayne Keller. How many years ago how long has the company been working with their FDA-approved trays and hydrogen-peroxide therapies, Tanya?
Since 2005, we got started.
Wow, so it's a 15-year-old company. And how long have you been with them?
I've been there since 2005.
Okay. So you've been there from the outset. So Dwayne Keller is a practicing dentist outside of St. Louis, specializing in TMJ and perio. Brilliant guy. Love to talk to him. He's just a great forward thinker. So last week, and you'll see where we're going with prevention. So last week, we had a think tank. And the think tank was with Dwayne, myself, Tanya, Dr. Alan Friedel, a doctor, I don't even know if Milton is a doctor or a researcher, and Kevin. Can you kind of tell us about the group that was in that think tank, and it's going to get us right into the role of hydrogen peroxide today? Would you mind, Tanya, talking about the group itself?
No, really happy to. So we called this group together so that we could begin to figure out new protocols potentially. Just to be clear, everybody's working with pretty scant data sets right now. So we're trying to figure out new protocols for keeping your team safe and keeping your patients as safe as possible. And because frankly, this virus isn't going away. We have to figure out how to live with it, and we have to get back to the business of patient care as quickly as we can. So we know... Go ahead.
So tell me Milton's background.
Yeah, so Milton's a PhD, biochemist, toxicologist. He is the lead researcher early on hydrogen peroxide, the use of it in dentistry. So when whitening became really popular in the 1980s, he was commissioned by the FDA and the ADA to lead the team to study the use of hydrogen peroxide, primarily for safety, but also for some efficacy. So we hired Milton a long time ago, I don't even remember how long ago, when we were running studies on hydrogen peroxide gels to figure out what was going to be the most effective at the lowest concentration. And also as a clinical trial monitor when the controlled clinical trials were going on, and as a GMP, good manufacturing practices auditor. So he's done a lot of consulting work with us over the years, and we just maintain, he's a good friend. I've totally enjoyed talking to Milton. Kevin, who you mentioned, Kevin Oberlander, as a pharmacist out of North Dakota. He was key in the formulation process of this particular gel. And there are formulated properties in the gel that are really good for what we're talking about now. It's gooey, it's thick, it sticks on surfaces better, which you want. So Kevin was part of that. You and Alan Friedel were both part of it as just really good thinkers who are also practically wet glove dentists. I value both of you so much for both the intellectual breadth and the kind of critical thinking that you bring to these conversations and strategic thinking. So that's why both of you were on. And then Dwayne, of course. Dwayne studied Perio. He decided in the end not to go the Perio route, and he ended up doing chronic pain patients. But he's our chief scientific officer, and he's the guy that leads this in terms of science.
So I think also another really interesting thing, and I'm going to bring Kevin on the show, is a lot, and we're not going to talk about it today. We've got too much to talk about on prevention, but Kevin talks about immunity, and immunity is that hot new buzzword in prevention. And I think as studies upon studies come out, the more immunocompromised a patient, obviously the worse for COVID outcomes. Right. But what Kevin was talking about, and I'm going to bring him back, is about what we can be doing immunity-wise with pharmaceuticals, and these are everyday pharmaceuticals. So I thought that was also a great takeaway out of the think tank. I'll bring Kevin back later this week, but let's get back to prevention. So hydrogen peroxide. There are recommendations out there by the ADA on rinsing, and I think I want to go a little deeper into that. Let's talk about the ADA protocols, the EPA protocols, and maybe where we can start to guide our audiences in being more preventive with hydrogen peroxide. I'm going to hand it over to you.
Okay, thanks. So the ADA came out with initial recommendations about using a hydrogen peroxide rinse, somewhere between a 1 and a 1.5%. The latest that I saw on their website was 1.5%. Data shows against coronaviruses in general that a 0.5% could be effective. They don't have a time point that they're recommending that you rinse. I would suggest also gargling with this mouth rinse would be, but we wouldn't expect it to have a longer effect than 2 minutes. So a liquid has this burst effect, and that means that it's limited in how long it's going to stay in the oral cavity as a potent before it completely breaks down to oxygen and water. The EPA recommends...
Go ahead. The EPA, yes, go ahead.
The EPA recommends that you apply hydrogen peroxide to surface areas and give it a 3 to 5 minute time period. So Dwayne started thinking, what is our right time point? I don't know. I want to make sure that my team's as safe as possible before I'm treating patients, and I want to make sure the patients are, we're keeping the patients safe too. So we have Perio-Gel. Perio-Gel is a 1.7% hydrogen peroxide gel. It's thick, it's gooey, it has adherence properties, and it takes a lot longer to activate and to completely break down into oxygen and water. It takes a little longer than 17 minutes in a tray. You would expect it to break down a little bit faster here with all the exposure to saliva, but still, it should have a longer staying power. So his thinking was,
Okay.
if I have patients brush with it, and not just their teeth, but their oral mucosa, their palate, their tongue, gargle a little bit, keep it in their mouth as long as they can, spit when they have to, and don't rinse. That would give our team, the dental team, better protection. And it should reduce, and that means like to reduce the risk of transmission because you have a longer contact time and a more effective application time. So that was the original thinking.
Okay, so let's go back to this. So obviously you could take generic hydrogen peroxide, 3%, dilute it with 2 parts water and get down to a 1% hydrogen peroxide. That would be the generic way of doing it.
Or half and half, right, either way.
Or half and half, it would be like, right, that would be like a 1.5%, correct. So, but again, I think it's really important to understand what the studies are showing. The studies are showing that if we can attack this virus in the mouth before it gets into the lungs or anywhere else, that's the essence of keeping COVID at bay. So here we are, we're always talking about hand washing, which I absolutely believe in.
Of course.
But now, if we start doing a daily regimen at home with, let's call it the Perio gel as our level 1 toothpaste, let's talk about if a dentist, the assistants, the hygienist, the entire team was going into the office, how would you describe what they could be doing before they go into the office about brushing? And then we'll bring it right to the patient. So how would you put a pea size, a little bit of the gel on your toothbrush? Does it go with the fluoride? Does it go before a fluoride? Give me the world of what you're thinking.
So in terms of like before, I would not do it with the fluoride. The fluoride's its
Okay.
own antimicrobial for bacteria. I have no idea if it works against the
Right.
SARS virus. So
Right.
if you want to
Yeah.
use your fluoride first, that's great. And then you would brush with this gel afterwards and leave it in your mouth as long as you can. Ideally, you won't spit for 15 minutes. You want to expectorate for, 3 minutes, not 15. Ideally, it's going to
Okay.
last that long, right? It should last about 15 minutes. But ideally, you're not going to expectorate for 3 minutes. At least. And then when you do, just don't rinse afterwards. And this would give you some protection. At home for patients, there are some people who are going to
Yep.
want to do everything possible to prevent this, which is fine
Agreed.
and good. But ideally, this kind of daily use is going to be an ideal situation if you believe you've been exposed to it, or you're showing symptoms and you think you have it, or you're confirmed that you have it, or somebody in your house is confirmed. Someone you come into close proximity with on a regular basis has been confirmed. For the time period that you would expect that virus to be active, this is a way, it's just an added layer of protection. So to be clear, this is not going to prevent the transmission completely, right? There's
Right.
a lot of different ways you
Right,
can get this.
absolutely.
This is just a layer of protection to reduce the risk of oral transmission. And we know from these new studies that are coming out that saliva is teeming with this virus. It's teeming
Right.
with it. And it's easy to get now, this new validation. What we had seen even before it was validated is that you just really need a very, very small saliva sample to be able to determine if the virus is
Right.
present or not, which is exciting because who wants that thing stuck up their nose?
Right. So let's go back to the brushing. So if you brush with this and basically just say, let's say you drool it out. So I've bleached my teeth. I've had Perio-Protect, and sometimes you have that oozing of that peroxide, and all of a sudden it does make you, I think, salivate more, and you may want to spit into a Perio-Protect cloth. I'm just thinking a little labeling for you, but what you're saying is let's let it be in the mouth 3 minutes. So let's talk about what a patient would do. People outside in the real world. Let's say they go to the supermarket and they're wearing a mask, which they should be. Or they go get gas, or they go to the pharmacy. I would think that the contact point where there's any potential transmission via breathing next to somebody, why wouldn't we wash our hands and do a rinse or the 3-minute brush when we get home? Because that would have been the most exposed time that we would be exposed to the virus. In other words, let's just keep the counts as low as possible. Would that be a wrong assumption on your end?
Well, without having the data, we would have to say that that's a decent assumption because this is what we talked about in our working group.
Right.
Like what
Right.
is the right time to recommend this? and the most appropriate time. So when you're coming into contact potentially with the active virus, that would be an appropriate time to be thinking about treating your oral environment. It's not just about your hands, right? And we've got some physicians that are using neti pots with salines and all kinds of different things for the exact same reasons.
Exactly. So let's talk about the dentist then. Here they are, now they're going to work. They're going to be exposed. I mean, they're wearing hopefully the right PPE, and the right PPE has been shown to be very preventative. Right. Let's just talk about they're doing all the guidelines. They're screening their patients. They're testing their patients, but nothing's perfect. Would you recommend perhaps during their workday that they do a 3-minute brush, or wear something that they could have a tray in their mouth to have the hydrogen peroxide? Again, just being preventative, because now the dentist, the hygienist, the assistants, front team, we're all front line. What are your thoughts about, like, even as a preventative measure during the day for the team while they're working?
So, we haven't even talked about the Perio tray, which I should explain to people who aren't Perio-Protect.
We'll get to that. We'll absolutely get to that.
If you're wearing this tray, you'd put a little more gel in it so it would leak out, right?
Okay.
But if you have one and you're on the team, yes, use your tray. A lot of people start out with active treatment twice a day. So we don't have a concern really with overusage here, especially with all this exposure to the saliva, because the salivary peroxidase will take effect. So I know what Dwayne Keller is doing, and he's suggesting that his team does this before they see new patients. And right now, your patient flow is pretty minimal compared to a normal day.
Right.
When you go back, when everybody starts to, as we reopen, we're probably not all going to reopen at the same time, but as we reopen and we get patients through there, we need to be thinking about the protection of the team and the protection of the patient. So a simple hydrogen peroxide rinse or using this gooey gel, in my mind, would be an appropriate use a couple of times a day.
And also for the patient, there's the rinse option, but even a little bit more thorough, they could rinse, gargle, and then do this brush for 3 minutes. I mean, that way we're also minimizing the cross-infection. At least we're just trying to minimize it, if you know what I'm saying. Agreed?
Exactly, right. We're doing as much as we can with the information we have, right.
Love it. So as we transition now from prevention, where I think I see selling this to my patients, doing an email blast or a text blast through Weave and saying we've got a preventative protocol. It doesn't prevent the disease, but we're just trying to minimize the potential of it. And I guess we'll have to carefully word this. Maybe your company can help us do that. But I could see sending out a text or an email to all my patients, and I could see hundreds of them going, can I buy a tube? And so I do think if we're going to send this email or text out, the offices better be ready to sell. We sell it for $25 per tube, and that's part of our Perio-Protect system. But I can easily see patients going, what else can I be doing? Right. And before this vaccine and everything else comes out, so I'm gonna leave that out there. But here's my question then next to you. Let's talk about your system, the RX Perio tray. Tell me why you think in this world that we're not going to be able to use ultrasonics, this could be a critical first step or essential step in maintaining our patients. Let's talk about your RX Perio tray system that your company's come up with.
Right. So the problem here now is we don't really have any good guidelines about what we should be doing or should not be doing for hygiene specifically, but also for all other dental procedures. And aerosols are the big question. So Perio-Protect, we have a tray that has an internal peripheral seal that the seal and the extensions work like a gasket, and the medication is pushed really deep into the periodontal pocket. So this is what we have been doing and teaching, tens of thousands of dental offices across the country. Right now, this is the perfect time to begin to talk about a really underused portion of our protocol. So we have two basic protocols that come out of controlled clinical trials. One is to use the tray before active therapy. It decreases bleeding, it decreases inflammation, you have some initial reductions, pocket probing depth scores. So there's two controlled clinical trials out there, separate examiners, there's a long 5-year case study. Anybody wants the data, happy to give that. But in practice, even really experienced Perio-Protect providers underuse that initial protocol. It is perfect for right now. using the tray before you go in and do any physical removal, debridement, scaling. Because at this point in time, you have so many patients with delayed care. So we got two different things we're talking about. One is team and patient safety. The other is just the business of patient care. What are you going to do with all those patients? You can't get them all through the chair. You can't get them all on your hygiene schedule. I know I'm talking to docs who say they're going to turn 2 of their dental operatories into hygiene, try to bring the hygienist in full time and start moving people through hygiene. Well, that's one way to do it also. But are you going to use your Cavitron right away? Are you going to hand scale? I mean, lasers come into a big role right now too. But the Perio tray is a great tool to use initially. So we're calling this the IRX protocol. So the Perio tray is a prescription tray. It's the only tray out there cleared by the Food and Drug Administration to deliver medication deep into pockets. So it is an FDA cleared, it's officially a medical device, but you got to write a script for it. So the IRX, the initial prescription, says you get, and if you've got a scanner, this is so easy. You get a scan or you get an impression of your patients, or you pour your bottles, or you can send it in, whatever, and we'll create a tray for you. Now, the original Perio tray has an internal peripheral seal that's fabricated according to pocket probing depth scores, and we always ask for current probe scores. You can do this without customized seals. You can do this with a uniform seal. It's just that the tray doesn't last as long in our experience, right? So with the customized seals in maintenance, you'd expect a tray to last at least 5 years. In a uniform seal, you would expect it to last a couple years. But right now, it's going to depend on how serious your patient's disease is. And if you don't want to get in and take probe scores in a mouth that you don't know is safe to be in, it would be safer and it would be less bloody, less inflamed, healthier all the way around if they use these trays for a couple of weeks before they come back in for active therapy or for their maintenance therapy.
Right. So let's talk about this, because I think hygienists want to get back to work and they're afraid, like we all are, of aerosol right now. Right. So we have already seen, you've sent me before and afters, and I've used this system, not what you're talking about now, but with Perio-Protect for before and after. So I want to tell the audience, this is how I see it. If a patient comes into your office, we could scan them or take traditional impressions, send them out to have these trays made. The patients would wear them really, Tanya, twice a day for 10 or 15 minutes, like in the shower or whenever else. And when they come in, the before and afters are unbelievable of how much better the gums look and how much less tartar or easier the tartar is to remove. And if we're doing hand scaling, then openly the hygienist is going to have a much better outcome. And then openly after the scaling, they're still wearing these trays to maintain the lack of biofilm returning, et cetera, et cetera. Isn't that the concept of what we're trying to get through with hygienists with this system?
That's right. And originally the concept was all about reducing the pathogen burden, reducing infection, reducing inflammation, which is still really important, right? We want to be able to get, your best bet is to reduce the burden on the immune system so that it can address other infectious challenges to the best extent it can. I mean, that's the whole, and we need to get back to that also.
Right. So I just want to close on this. So what Tanya and I are discussing is that this gel can be a wonderful adjunct to what we would say is minimizing the exacerbation of what the COVID can do. If we can minimize it spreading potentially into the lungs, or if by chance some virons have come into your saliva at a low dose, I see this hydrogen peroxide therapy just by brushing and or rinsing or a combination thereof. You can't lose with this in that theory. We can use this as a protocol before we put the patient in the chair as a pre-rinse or a pre-brush. The dentist, the team members can all be using this, potentially brushing or using this kind of tray throughout the day or at intervals throughout the tray to minimize transmission and the interaction of the virus. And now we can preventively or try to treat patients almost prophylactically by taking impressions and letting them really work with us in biofilm management. Is that kind of a good synopsis today of our discussion?
That's a really good that's a very good synopsis. And anybody who wants more, we're doing free training for dentists. You just need to contact us at Perio-Protect.
So they would go to Perio-Protect.com. I would also tell you, we're probably going to love you to host a webinar at Midway. We'd probably love to host at Catapult. I mean, we'd love to have you back on. And I'm going to also announce, as I close today's segment, you're going to be a panelist next week. And you're going to go, I am?
I am?
So exactly. So here's what we've got. This has grown beyond. The new norm has grown beyond even dentists and team members. We are getting, I'll say, pleasantly inundated with questions from consumers to team members to patients. We can't answer all these questions. It's unbelievable, but we love it.
There is a thirst for information right now. It's really important work you're doing.
Exactly. So as a team, yesterday, the Midway team, we all sat down and we are going to launch the new norm town hall. And the idea is we'll have a Zoom meeting. We're going to have panelists from the week before, and you guys can email your questions just like you are. And what we're going to do is we're going to compile those questions into a forum. We can have up to 1,000 people attend through a Zoom meeting. And we're going to be hosted. Our moderator will be a wonderful hygienist, and her name is Samantha Wendell. She works with Midway, and she's going to be our moderator. I'll be a panelist. I'll have a Catapult member join us. Ron will be with us next week. I'm going to absolutely have Tanya, and we'll have one more panelist. That might be in 2 weeks, because we may do an OSHA group next week, because I think we have so many OSHA questions we've got to get back to. So we're going to figure out this town hall. It's going to be, I believe it's 9 or 10 o'clock on Tuesday mornings. If you go to Midway and register, that becomes critical, because if you register and I'm going to get it, at midwayedu.com. If you register at midwayedu.com, you'll be on our list. We already are close to 1,000 at this point. And this way, we'll let you know about our town hall. We'll update you. And it's honestly, I think it'll fill up really fast. So we'll be doing that live next Tuesday. Tanya, I can't thank you enough for sharing your morning with us, sharing all your information. And I think a lot of us are going to be distributing the Perio-Protect gel, not only in our own homes, but to our patients, and hopefully get this IRX treatment philosophy going. Thank you so much for being here.
Thank you, Lou, and everybody at Midway. I appreciate your interest.
Thank you. Have a good day, everybody. So let me be clear. We want to hear from you. We want to hear your questions. So what we want you to do is we want you to go to education@midwaydental.com. Shoot us your questions. We'll go right to the experts. I know I'm not the expert, so let's go ask the experts what we should be doing as our next step next week, the week after, and thereafter. I look forward to hearing from you.